nursing workforce, how to build a fit for future workforce, organized by Wolters Kluwer. So I am Dr. Dravid, the marketing manager for Wolters Kluwer. I will be your moderator for today's event. Our objective for this webinar is that the participants should be able to learn how to change the patient healthcare for the better. The participants will have the opportunity to submit the text questions to today's presenters. So they can type your questions in the question pane of the control panel. So you may send in your questions at any time during the presentation. So we will collect this and address them during our Q&A session as much as possible at the end of today's presentation. For more information, a recorded version of this webinar will be available and will be shared with the participants who have registered and participants who are present there. So now I would like to introduce today's expert speakers. So we are 4 expert speakers on the panel. And the first one is Colonel Binu Sharma, Vice President, Nursing Services at the Columbia Asia Group of Hospitals. She is an integral part of the hospital operations team and is also a certified NABH assessor. So she is specialized in critical care nursing while in the Army. So she is the General Secretary for Infusion Nursing Society India, US affiliate chapter. And Colonel Sharma has been awarded with Commendation Medal Eastern Command for exemplary nursing services. And she has also been the recipient of Florence Nightingale Award in 2007. She has also authored many articles on nursing, and she has published those articles in domestic and international journals. Our next speaker is Professor Suresh K. Sharma, who is the professor and principal of College of Nursing from AIIMS Jodhpur. He is a fellow of ICN Global Nursing Leadership. He is currently the president of Perioperative Nursing and Society for Critical Care Nursing India. He has served in many national level committees and he has a keen interest towards academics and research. He has authored and published many journals and books, and he serves on the editorial board for journals like Journal of Nursing Education and Practice and Journal of Medical Evidences. And then we have Colette Hendler. So she's joining us from the US, and thanks, Colette. I know it's very early in the morning, and she is the editor-in-chief for Wolters Kluwer, Lippincott Solutions. She is certified by the Certification Board of Infection Control and Epidemiology, and she is an infection preventionist. She has more than 20 years of experience in critical care nursing, and she maintains alumnus status as a critical care registered nurse. And then we have our fourth and final speaker, Amy Allen, Senior Training Manager from Wolters Kluwer. Amy has 20 years of experience as a trainer, implementation consultant, and an account manager at Wolters Kluwer, and has won numerous internal awards as a leading performer in her field, with a close involvement in Lippincott Solution implementation in North America. Amy has a rich understanding of the needs and requirements of a broad range of clinical and academic organizations, and how the Lippincott Solutions resources can support the nursing workforce in delivering clinical practices based on the current and best evidences. And for those of you just joining us, welcome. I welcome you all once again. Now I'm handing the control to Colonel Binu Sharma. Colonel Binu Sharma, welcome you once again, and the floor is yours.
Thank you. A very good afternoon to everybody, the eminent speakers on the panel, as well as our eager participants who are in for a 1 hour of learning and orientation. Very interesting topic, getting ready for future. Do we ever get ready completely? I'm really surprised. I don't think so. Having been into nursing for last 43 years, way back 1977, my journey started. I worked in the Army hospitals, Navy hospitals. I worked in the corporate world, group of hospitals. But we always seem to be falling short of being ready to take on the challenges for managing patients, because the healthcare world is really so dynamically changing. What you have as midnight stats is what changes in the morning and changes every few hours. So with that, the title is so interesting, Learning Never Stops. So building an excellent orientation and competency for our team members, for our nurses. So let me just take you through a few slides and my experience, and let's hear from you all at the end of the discussion. So just setting the context, more than 4,000 nursing institutions in the country, which churn out more than 2.5 lakhs nurses every year, which is graduates, general nurses. These are the Indian Nursing Council stats. Graduates get various kind of job offers. They go to nursing homes, they go to clinics, they go to daycare centers, they go to hospitals. They also go to places like a path lab, diagnostics, pharmacy, etc. And the last line, not so encouraging, is our fresh graduates, fresh GNMs are paid a very low salary, starting with anything between 7,000 going up to 20,000 in the private world, and different salaries in different states in the public hospitals. So that is setting the context. Can we move on, please? So when a nurse comes in, what is it she faces as difficulty in an organization? We are talking here of as a fresh graduate or as a fresh nurse in the career. What is it you are in for challenges? Enormous pressure to meet professional expectation. When you come in a nursing uniform, everybody expects you to know everything. Nobody is aware or does not remember whether you are a new joinee or you have an experience behind you. And our nursing education really does not prepare us completely for being job ready or for being patient ready, I would say. Expertise in clinical nursing is very, very important for patient care, but we do not get enough hands-on when we are studying in nursing school or college, because a lot of private hospitals do not have a parent hospital, and we do not get the hands-on experience, which is so much uh, necessary to build confidence. We do not get enough chance for managing enough patients, whether in the OBG, whether in the pediatrics or in the med surg or across. There is a huge gap in the quality and consistency of nursing education. You study in a government hospital or government run college, you have some hands-on volume of patients, large numbers you are able to handle. You get a chance to carry out a few nursing procedures. You might be able to would have put a Foley's catheter, a NG tube, you may have put in a cannula. But when you are going for your practice as a student to the private hospitals, all of this may not have been possible, because private hospitals have to manage the image of the hospital, patient experience, and many things they do not want to take a chance. So the freshers are unable to manage expectations of the patients, expectations of the nursing leaders, and expectations of the administration which has hired them. What it does, it makes fresh nurses to have not enough confidence, they have high workload, they have orientation or induction issues, there is fear, there is anxiety, they are completely overwhelmed in this scenario, straight from a college environment, coming to a hospital, and it is so difficult for them, and they get into a emotional and a physical burnout. And I've seen that so much among the freshers. If I can quote, we did a quality improvement program across our 12 hospitals to see the high attrition in some of the hospitals. And when we started doing the slicing and dicing and root cause analysis, we found highest number of people who left were actually the freshers. Within 3 months of joining, they left. They came with such high expectations, enthusiasm, energy, looking forward to future. What happened? Within 3 months, they could not cope up with the pressure and they exited the system. And the sad part is, we as administrators could not pick up the signs of stress, emotional trauma, physical burnout. the difficulties they were facing, and we lost them. We hired them with so much of expectation. They came in with so much of expectation, but we lost them. Can we move on to the next slide, please? Yeah. So what happens when somebody joins new? What are the goals we have for them and for the people who are orienting them? First of all, improving quality of care they provide, hence reducing variations in care. If you have students, you hired 100 students coming in from 10 different colleges, can they deliver nursing procedures, nursing care with the same quality and standardization? One of the goals we have. Reducing risk and increasing patient safety. The motto of patient safety is do no harm. First, do no harm. The people who come new are so very scared, even though they would have read things in the textbooks, they would have given exams and scored a first class in their final year, but they end up committing mistakes. Hence, there is increasing risk on patient safety. Emphasizing primary care and accessibility to services. So our fresh team members who come in, for them to understand the gamut and scope of services is a major exercise for a nursing leader. Engaging in interpersonal communication and collaboration and a team-based approach. When we do carry out nursing engagement surveys, I do the survey every year and it's an anonymous survey. People are not required to reveal their name or other details. And we do that so that we can get a real feedback from our nurses. So what we get to see the highest among the top 5 reasons when people fall short in delivering excellent nursing care is they do not have enough adequate interpersonal collaboration. Every department works in their silos. There's radiology, there is lab, there is an operating room, there is a ward. Nobody talks to each other. Nobody understands each other's challenges. Another goal is strengthening the overall system through education and professional development. That is the main tagline. If you strengthen the induction process, the orientation process, then you will be able to deliver all other goals. Advancing technology. When we are in the college, when we are in the nursing school, we do not get our hands on the modern medical equipment, the syringe pump, infusion pump, the monitors, the ventilators, all new machines, the electronic health record, the hospital information system. We have no clue about it. All of this creates a lot of stress for newcomers because they got to learn and they got to deliver. And targeting reductions in cost and increasing in benefits, we do not really expect that from a fresher, but ultimately hospitals do have that as a target. Their wastages are less and there is value for money. There is enough return on investment of the people they've done. So can we move, please? Demand versus supply. So the current supply, we just saw that 2.5 lakhs nurses pass out every year. And we still have shortage of nurses in our country. Why? We have that because, first of all the people who come out of these colleges are not job ready, number one. Secondly, a lot of them, by the time they finish nursing, many freshers have already lost interest in carrying on with the profession. We are seeing that in last 1 decade. Thirdly, many of them join colleges for teaching jobs. Many of them join the program which is making them ready for overseas employment, and in few months or less than 1 year they want to go to overseas. So we will continue to have these supply versus demand issues. It is critical to have a well-defined strategy for onboarding people, for hiring people, for training people, for getting them ready to manage patients. And the sooner we are able to achieve that as a nurse leader, the better it is for the nurses, for the nursing leaders, for the administration, and above everything for the patients, because everybody needs the right care or safe care. Can we move, please? So, new hire onboarding, orientation, and a mentorship program. Onboarding and orientation are usually used interchangeably as coaching, mentoring, precepting. Onboarding is a process where you integrate a new person into the organization. It can be for anybody, it can be for a fresher, it can be for a VP nursing. Orientation are the activities you carry out which are associated with introducing them to their role and responsibility, their duties, their position, the infrastructure of the hospital. So, orientation is important when employees are joining new, when employees are changing role. For example, if a nurse moves from a ward nurse job role to the operating theater, pre-operative room, she needs orientation there. Transition from one service unit to another. If you are going from a ward to the critical care unit, you are changing departments, you are changing job role. If a staff nurse becomes a charge nurse, or a charge nurse takes the position of a manager, orientation is required. Hence, keeping that in view, in my organization, we have defined and designed orientation tool for every single department. I will have a orientation plan for a ward nurse. I'll have a orientation plan for a ICU nurse. I'll have a orientation plan for a chief of nursing, a plan for the clinical educator, for the infection control nurse. Every single department in the hospital, there is a structured, customized orientation tool prepared. And we do that with the help of so many training development platforms. In fact, we've used Walter and Clewer for multiple years across Columbia Asia hospitals, and the nurses found it so very valuable. Likewise, there are so many other platforms which you can use when you wish to design these various job roles or various specialty requirements for your nurses. Can we move on? Wayfinding for new hires. So what is it we do? We need to have an onboarding structure. We need to have an onboarding process. And we also need to define the onboarding outcomes. I go as an NABH assessor to multiple hospitals. There are some places you find some structure which may be ill-defined or well-defined. Somewhere you don't find a framework, but you find some processes on induction of people. And some places you find end-to-end beautifully chalked out a structure or a framework, the processes which need to be there, and the outcomes which we need to see after we have finished the onboarding and the orientation. It starts with the structure. You need to have a structure for recruiting people based on the job requirements you have. You need to have the initial induction and orientation. I'll explain that a little later. You need to have a competency assessment. You need to be able to verify and map the competencies. You need to have a buddy system, a preceptor system, or a mentor, and you need to have adequate time for a role transition. When a graduate comes in, they need a different transition time than when an experienced nurse comes to you. For example, a fresh graduate coming as a ward nurse, maybe you need a longer time because you have to orient her to everything. A experienced ICU nurse coming into your system, going to your ICU, you will need a shorter time there. In terms of the processes, you need definitely, you have to help the newcomer to adjust to the new environment, new role, new hospital policies, protocols. Give them role clarification on the day of joining. People feel lost if they do not know what is expected out of them. Also, give them a copy of their position guidelines, which contains the job role and responsibilities. Also, give them key resultant areas or key service areas. What are they expected to do after this? For example, a nurse shall be able to give medication safely, oral medication safely to all patients, or injectables and IV therapy. You need to define that very well, and you need to help the newcomer to integrate with the teams they are working, which does not mean only nursing team, which also means doctors, which means all other departments in the hospital. And then in terms of outcome, the candidate should be able to have a successful transition into the role, into the hospital. There should be good employee satisfaction. They should have loads of confidence. They should have improved performance. And at this level, for the first 3 to 6 months' time, you should have more retention and less attrition. Thank you. Can we have the next slide? So, goals of orientation process, the new hire has to be aligned with the vision, mission, and values and culture of the organization. Every organization is different. If I'm working in a private corporate level hospital, when I'm working in a new small nursing home, and versus when I'm working in a public hospital, a massive mega size CMC Vellore or AIMS Delhi, I need to be aligned to the vision mission. I need to acquire accurate recruitment, interviews, selection for hiring or for transfer. As a nurse leader, you need to have the right people for the right job, accommodated with the orientation and mentorship program. The tools need to be provided. If you have booklets, orientation booklet, safety goal booklet, give as much material to the nurse as much you can, or put it in a soft copy on the desktop, on the laptops, assimilated into new service and interprofessional team. Once you develop trust with each other, which only comes when you know each other, you develop trust, you'll develop a excellent IPR, and you'll be able to function better and accelerated to assume new team roles and responsibilities. And before you give them that role independently, you should have been you should be sure that the person is confident enough and not a novice still in the job role. Service specific orientation, our nurses, when they come, they have excellent knowledge. They have studied everything. But service specific orientation for the transition is extremely important, which includes communicate initial performance expectations. So what we do, we give a job chat or a job role sheet, which has few bullet points, which is written in bold, that these are our expectations. Provide hands-on training. There are few basic procedures which every nurse has to know, like assessment of a patient, making a care plan, monitoring vital parameters, IV cannulation, position change, hygiene of the patient, managing NG tube. Very few basic hands-on, but they have to have this basic hands-on knowledge. Introduce new hire to the work unit and to everybody. Take pride in introducing them. Remember their name, give their name of the college, give their qualifications, introduce them to the doctors in the department. They'll feel so nice and so important. Review and validate initial competencies. So we have a self-assessment form in which there are activities written or parameters written. The nurses, after the initial induction, can do a self-assessment, what they can do independently, what they still need supervision, and what they cannot do. Let the nurse decide. If she ticks everywhere that she can do everything independently, then it is for the team leaders or the supervisors or the managers to validate whether they're writing it out of fear or have they really imbibed everything. Integrate the new hire fully into the team. Most important, you need to get them together as a team. They'll work fantastic. Can we move on? Schedule frequent meetings for feedback. So let me give an example here. As I said, when we were doing the QIP for new joinees, I found in the first 3 months, a lot of people went out of the job without even explaining the reason. We started a very informal program, which is known as Coffee with CNS. CNS is our Chief of Nursing Services, who is the nursing manager or head of the hospital. Like you would have seen a program on TV, Coffee with Karan. We came up with a program, Coffee with CNS. So informally, we will meet them in the staff cafe, informally anywhere. We'll sit down with some of them. We'll ask them how are they doing over a cup of tea or coffee, and that helped in breaking the ice. that helped in letting us know their difficulties. In fact, I am in a corporate role managing 11 hospitals, but I used to definitely walk into the induction room, walk into the program of coffee with CNS, and I would myself chat with them. This really created a magical change in the way the newcomers thought of themselves. They became so confident. I would share my number with them. The CNS would share our mobile number with them, and they can reach out anytime. So that changed our scenario. Document performance competencies, learning and team building activities. Do a lot of evaluation, engage them in a lot of projects, engage them in defining SOPs along with the senior team. Provide progress report not just to the nurse manager and the supervisor, but to the team member as well. And again, this is one of the parameters we got from the employee engagement survey, that we do not come to know about our performance till that entire 1 year is complete. So we started giving them quarterly feedback on their performance, areas of improvement, what are their strengths, where they can improve, and continue the mentorship and preceptorship throughout the service orientation. In fact, we have a program where we assign a mentor to every newcomer for first 2 months. It has helped us to stabilize the newcomers in the system. Next slide, please. So components of the orientation program, definitely in that you can define lot many type in the framework, but definitely there will be preceptorship, classroom-based activities, skill-based activity, simulation-based areas if you got in the hospital, bedside learning with senior nurses, allow them to do clinical practice once you gain little confidence in them, and allow them to try things on their own. It shall also include HR policies and nursing protocols and policies, safety culture and environmental culture of the hospital, infection control protocols, emergency procedures, emergency codes, managing code blue, code gray, code pink, incident reporting if there is something, if there is a conflict, where do they reach out, grievance policy of the hospital. If they see any sign of stress, how do they reach out? Whom do they reach out? What can be done for their professional development? What is it they are lacking? How do they achieve service excellence? What is the meaning of excellence? Quality in everything what they are doing. Patient and employee rights and responsibilities. They'll need to learn communication, which is verbal, which is written, and which is also electronic. And above all, they need to know, they need to understand everything to be done with the code of nursing ethics. That's important. Next slide, please. So also some more trainings which the nurses need to know. End of life care. You may have patients who are terminally ill. Blood transfusion practices, policies and protocols. Use of medical equipment, what is required to be used by them in the areas they work. Human organ system and relative departments, cardiology, respiratory, different organ systems to orient them again. Trauma and sepsis management, simulation-based procedures, whatever is possible, computer-based training and online. We do a lot of online training. In last 2 years, we moved to webinars, training of the nurses through Microsoft Teams. We could do procedure demonstration. We could do everything through online activities. Provide new hires with information and the schedule for the activities. Initiate a new employee preceptorship program, schedule new hire for interaction with their mentors, coaches, or preceptors, review role and expectations between them during the onboarding time, during the induction time, arrange more and more learning opportunities, send them for more classroom based classes, send them for all the CNEs, maximum possible for a newcomer, so that they get the confidence and they have the orientation required. Next, please.
Can you, yeah, ma'am, we are just shortly running out of time. Yeah.
Short of time. Okay, I'll expedite. Yes, please. So these are competency building. Basically, what we are seeing here, from a novice to the proficiency level, you take the journey of the nurse right from the time she joins till she reaches a proficiency level. These are the abilities and different levels required. Can we move on, please? These are components of nursing competency: ability to build IPR, ability to give care, collaborate with team, expand professional capacity, support decision making, and ensure that they deliver high quality nursing care. Yes, please. Evaluating the orientation program, you should be able to evaluate it so that aspects which are evaluated, their own satisfaction, the management of cost, time effectiveness, their critical thinking, decision making, your attrition rate, your retention, performance of the employee, their engagement with patients and engagement in the hospital, overall confidence and effective care is how you need to evaluate your orientation program. Evidence-based suggestions, these are some of the evidence-based suggestions that novice nurses period should be at least 4 weeks. We have got the period initial 5 days of induction and about 6 to 8 weeks of departmental orientation. Many studies also say a successful program can increase the job satisfaction. So have the buddy system, have the mentors or the buddy. Senior nurses, if they become buddies, there is high rate of satisfaction. Simulation-based trainings add a lot of value, and specific information based on different quality standard will motivate nurses, the novice nurses to learn better, and orientation geared towards improved competency, ultimately the best outcomes in patient care. Thank you. Next slide. I think we are done. So in conclusion, it should be aligned with evidence-based research, and this is just summarizing everything. Orientation program should include measurable goals to evaluate nurses that they are job ready. With that, I thank all the participants and everybody for patiently listening to me. Thank you, David.
Thank you, ma'am. Thank you, ma'am. It was a wonderful talk. I think the participants will have questions regarding what are the programs which you have enforced in your institutions. So we will take it in the end, but it would be an enriching experience. So now I request Colette to join the speaker panel while I project the slides. Colette, over to you.
Okay, thank you. Today, healthcare organizations globally face a variety of challenges, and perhaps the biggest challenge is delivering high-quality, evidence-based care efficiently and economically, and doing that while ensuring that the care improves our patients' outcomes. They're also overwhelmed by the volume of published healthcare information. In fact, we've seen an 8 to 9% growth in the number of research articles that are published each year. In fact, it's estimated that 2 million healthcare articles are published annually worldwide. And when you think about that, it's a staggering number of articles for clinicians and healthcare organizations to sift through to ensure that they're following the latest best evidence available to care for their patients. Healthcare organizations also struggle to transition research into practice. And one study revealed that it typically takes about 17 years for research to get implemented into practice. And that's time wasted where patients could benefit from receiving better care. Many organizations also must navigate through shortages of staff and supplies. And this was really evident during the COVID-19 pandemic as organizations struggled to staff their facilities and supply staff with the equipment needed to provide quality patient care. Next slide, please. Evidence-based care plays a key role in combating these global healthcare challenges. So let's take a look at how the nursing profession came to embrace the concept of evidence-based practice and how it can help combat those global health challenges. So before the mid-1800s, nurses largely performed domestic tasks such as sweeping hospital floors, serving meals, feeding patients, and any other task really that was requested of them by physicians. But then Florence Nightingale advanced the nursing profession with her work in military hospitals during the Crimean War. And that was beginning in 1853 and lasted for about 3 years. And although she is not officially recognized as the founder of evidence-based nursing practice, Florence Nightingale has been credited by some nurse researchers for beginning the concept of improving patient outcomes by applying sound evidence to care. And after the war, she was asked to manage a hospital in Turkey that was known for its unsanitary conditions. And there she observed how the hospital environment affected patients' health and outcomes. And then based on her observations, she implemented interventions that improved patient hygiene and environmental conditions and ultimately improved her patients' outcomes. Then in 1972, Archie Cochrane, he was an epidemiologist who introduced the concept of incorporating research into practice. And he largely focused on the value of randomized control trials. Before that time, care was given mainly based on assumptions. And I know that was true early in my nursing career. When I began working in the intensive care unit, we suctioned patients who required mechanical ventilation every 2 hours with an open suction system. And it was assumed that if we didn't suction the endotracheal tube every 2 hours, the airway would become obstructed with secretions. And as a result, we actually caused patients trauma, and we unnecessarily invaded their airway, increasing their risk for infection. And on top of that, we wasted valuable resources and increased costs both to the patient physically and to the facility because our intervention was based on assumption and not science. Next slide, please. David Sackett introduced the term evidence-based medicine in 1996, and he focused on research, clinical experience, and patient values. And it was soon after that that nursing and other disciplines adopted Sackett's concept, which became known as evidence-based practice. Next slide. So let's take a closer look at the elements of evidence-based practice. So it incorporates the best scientific evidence from scientific literature, in addition to data that's collected from patients. But it doesn't stop there. It also incorporates clinician expertise and expert opinion that's been acquired from professional clinical experiences. And it also is very important that it includes patient values, goals, and personal and cultural perspectives. Next slide. Evidence-based practice follows a process in which clinicians frame a clinical question about a patient, problem, intervention, or outcome. And it's really important that this question be well designed and identify the patient population or problem that the clinicians intend to study, the intervention or treatment that they're considering, and then have a comparison to another intervention, as well as stating the desired or expected outcome or the objective. And the time frame should also be specified in this. And that's the period of time that it will take for us to reach the desired outcome. And then after identifying the question, clinicians should search for relevant internal and external evidence to answer the question, and then appraise the evidence to determine whether it's high quality and relevant. And clinicians should institute these clinical changes using the best available evidence that they find, and then evaluate the incomes that resulted from applying the evidence. And it's really important that evidence-based practice remain fluid. And as clinicians, we should always be asking questions in pursuit of the best evidence for our patients. So why is evidence-based practice so important? Well, you know, research shows that evidence-based practice eliminates care variability, it improves patient outcomes, ensures patient safety, reduces healthcare costs, it maximizes reimbursement, and it empowers clinicians to ask questions and take an active role in improving care. And it also increases patient satisfaction because now our patients are informed and expect a certain level of care. Next slide. So I mentioned that evidence-based care reduces care variability. So let's talk a little about that. So there are two types of variability. There's operational variability and knowledge variability. Operational variability occurs when there are differences in clinician care delivery. So irregularities can occur during a single activity in the care delivery process, even when clinicians provide care that's based on the knowledge of that patient's diagnosis and treatment plan. Knowledge variability, on the other hand, occurs from differences in clinician expertise. And as was discussed earlier, clinicians come to practice with a range of expertise. So we have clinicians who range from novice to expert in our facilities. And moreover, our care recommendations change frequently, so it's difficult for clinicians to keep abreast of the latest changes. Next slide. So why should we care about care variability? Well, care variability negatively impacts care quality and patient outcomes. So by using evidence-based information to standardize care, clinicians can eliminate that variability. They can increase the efficiency by which they deliver care. That ultimately will improve patient outcomes and provide a better patient experience, while also reducing healthcare costs because we're eliminating waste and we're maximizing reimbursement because we're doing what experts, what regulatory bodies expect us to do in the care of those patients. Next slide. So how do we go about implementing evidence-based care in practice in a healthcare facility? Well, first, it's really important to create a workplace culture that supports evidence-based practice. And this starts by obtaining administrative support. It's also important to identify champions and to engage staff and also students in the evidence-based process, and to initiate quality improvement projects and provide clinicians with evidence-based resources where and when they need them. Next slide. So clinicians need access to this evidence-based care at the point of care for clinical decision support. They need quick access to information that's presented in an easy format that's quick and easy to read, like bulleted lists, preferably content that's embedded or linked to the electronic health record so that it's right there in their workflow. Clinicians also need evidence-based information at the point of reference. And the point of reference contains more information than is needed at the point of care for decision support. This information usually includes information to inform practice, research, and quality improvement. And this is information contained in databases, journals, and books, and it should be diverse content that limits research bias. Clinicians also need access to evidence-based information at the point of learning. And this information contains basic and advanced education resources that support education in orientation and preceptoring and that type of thing. It also includes continuing professional development education and competency support. And so there are a variety of sources for point of care, point of reference, and point of learning to support clinicians as they deliver evidence-based care. And on the screen, you'll see that there are point of care products such as Lippincott Procedures and Advisor and the 5-minute clinical consult, up to date. These are all good resources that can be used by clinicians at the point of care when they're caring for their patients. At the point of references, there's journals, books, databases such as Ovid and the Joanna Briggs Institute. And at the point of learning, we have learning modules in our professional development collection, and also simulation products that can support nursing education. Next slide, please. So at the end of the day, evidence-based practice is all about caring for people, for our patients, and for improving their outcomes. And so as healthcare professionals, it's really important that we make sure that we're putting the best evidence into practice and that we're asking the proper questions and doing our part to contribute to that evidence that's being used to improve these patient outcomes. So thank you for your time.
Thanks, Colette. I think participants would be able to have a look at few of our solutions. So next, I would ask Dr. Suresh Sharma to come on the show, please. Meanwhile, I will share his presentation.
So, Dr. Dravid.
15 minutes, sir. 12 to 15 minutes, yeah.
Perfect. I'll do that. So my hello to Binu Sharma, Colette, and Amy who are sharing podium with me today. Dravid, will you be sharing my slides, or should I do it?
Yes, sir. Yes, I'm sharing.
Perfect. So primarily, I'll be talking today about how we need to reform the nursing education and what we need to do so that we have the nursing workforce who is ready to take a job. Colonel Binu Sharma was speaking that the nurses they receive in their hospitals, they are not clinical practice ready. So they do develop the stress, burnout, and hospitals suffer, and patient safety remains always in question. So it is very, very important that in nursing education, we need to bring a change so that the product which comes out is of best quality to immediately suit the healthcare needs, and care which are expected from a nurse in general and in specifics. He can take it up. Dr. Dravid, will you take time to share the slides?
No, sir, you can share. I've given the rights to you. You can directly share.
Okay.
Yeah.
Okay, thank you. Can you see my slides?
Not
David,
yet, sir.
can you see my slides?
Not yet.
Sir, I will try to share it your class, so I don't know issues about it.
Yes, please.
Yeah. Yeah, we can see. Yeah.
Perfect. So I'll be speaking today about teaching tomorrow's nurses and transforming education and future of nursing education in India. Next slide. So if we look into the current status of evidence in 2020, nursing workforce size and professional scope is expanding in any country. However, there are inequalities and insufficient to meet the rising demand, and some of the populations remain deprived of the quality nursing care. Nurses should achieve higher level of education and training through an improved education system to promote seamless academic progress and patient safety. Next. So the three generations of education reform progress during past century, if we look into the first generation launched in beginning of 20th century and taught a science-based curriculum, which was borrowed from different disciplines of science. Second generation, a problem-based instruction innovations. And third generation, which we have now, and core professional competencies we need to focus. Next, please. So you can see here in 90s, instructional and institutional curriculum. Now, later on, science-based curriculum, whereby there is a scientific curriculum, university-based curriculum, education. And then we shifted to the problem-based curriculum in Western world, but still in India, we are stuck up to the scientific curriculum and university-based education. So in problem-based curriculum, there were the academic centers where the education was happening. And now they are driving competency-based local to global focus, and health education. System-based education started happening into the best of the universities, rather than isolated academic center and university education, and then suddenly they have a jerk when they enter into healthcare delivery. Next. So you can see here, there's a population and there's an education system and health system. These two systems are parallelly running up, and education system had its need, demand, provision, and supply of healthcare professionals. Whereas into health system, there's a need, demand, provision, and demand of healthcare workforce, and labor market for healthcare professionals are prepared, and the healthcare system guides how education system should be. But unfortunately, in country India, since last more than 50 years, we have not changed our neither curriculum nor education system. Next. If you look into the structure, we have institutional design and we have processes where there's a systemic level where there's a stewardship or governance, financing, resource generation, service provision, organizational level we have ownership, affiliation, internal structure, global level we have stewardship and network partnership. These are the structure which is we are expecting and prevailing in some of the countries, and they may be deficit at some level. And there is a context of global and local level, and there are processes like criteria of admission, definition of defined competency, channels, and career pathways. And then there is a proposed outcome, that is independence in education and transformative learning. This is an ideal structure, process, and proposed outcome which we are expecting. Some part of it is existing in our system, but large part it is not existing. But fortunately, in Western world, they have moved ahead. Next. So you can see health system here, and there are emerging challenges in health system. There's epidemiological and demographic transition. You can see the new pandemic, which has shown us a different type of challenges. Professional differentiations started happening of different core and micro specializations are emerging into our partner disciplines like medical sciences. There are different population demand. Today's patient is demanding quality of care. Now the healthcare professionals are not equal to board. They are service providers and patient is consumer. There's a technological innovations. Every day there's a new technologies coming up, and these are the challenges which are transferred to the education system where vision with healthcare system. Next. Now, new era of professional education required transformative learning and interdependence in education. Competencies need to be defined and global flow of information need to begin. It cannot be now to a localized to one country or one region. And reforms into all countries are required because there's a inter-country migrations of nurses. From India, nurses are going everywhere. So developed countries, if will transform into their health education system, will not help them because there's a deficit of nurses everywhere, and there are some countries that are producing more. If there will be substandard of nursing education happening in these countries, the safety of the patient suffers into Western world as well. Sound evidence and individual and population-based approach and instructional and institutional innovations are required for new era of professional education. Next. So you can see here transformative learning and independence into education. We can't use pedagogy more. We need to give independence to a person by telling that these are the competencies you need to acquire, and these are the expected objectives from this program. And equity into healthcare that happen with individual-centered patient care and population-based care ultimately governs and guide this process of transformative learning and independence. Next. So you can see proposed reforms are of 6-point reforms, which I'll be proposing as per my own opinion. We need to adapt the competency-based curriculum. We need to promote the interprofessional and transprofessional education. We need to use IT into larger level, and pandemic has given us a leap for 6-7 years of use into IT into our education system. We need to think locally, but we need to have resources globally and guide our whole process globally. We need to strengthen education resources like faculty, syllabus, didactic material, infrastructure, etc., like IT infrastructure, skill labs. And we need to infuse new professionalism among nurses and new professionalism umbrella concept, which every one of us know, professional and personal grooming, soft skills and core skills. Next. So we need to, I'll take one by one. Adaptation of competency based, we need to shift from transitional curriculum where we have curriculum objectives and assessment. But we need to shift based on health needs and of health system. We need to design competencies and competency outcomes. We need to drive the curriculum based on that, and we need to carry out the assessment based on that. Next. The second thing is, interprofessional and transprofessional education. Healthcare is a team. There's a doctor, there's a nurse, there's a paramedic, and other support staff. Education must have initial level together, and then they learn their specific. So they understand what are the boundaries and scope of practice of each other, and they understand and respect more each other. And this started happening in Western world, but in India still we are doing compartmental education for nurses separately, for doctors separately, for paramedics separately. Next. And this is how the transformational model is based on that. You see that model of interprofessional and transprofessional, where pre-secondary education, they all are same. They are doing 10+2 science, either it's a nurse or a doctor. And then there's a post-secondary education are happening separate. And then ultimately they come into health system and work as a team together. So why don't we teach them as a team while teaching, so they understand the scope of practice, and then the respect, they have a mutual respect with each other. Next. The power of IT, everybody can appreciate now. And we need to harness in newer forms of transformative learning mode through IT revolution. And the tablets in classroom, assistive technology in teaching, augmented reality, virtual reality, voice platform, simulation, name these, this has to be brought to nursing education if we really would like to transform the way we are training nurses. Next. Simulation at large we need to use. Our simulation labs are very poorly equipped, and we are compromising patient safety. If we are directly introducing a novice nurse to build a skill on a patient, the patient is at risk, and the novice nurse under serious anxiety. Next. Educational resources, yes, we need to build a faculty development programs. We need to bring syllabus or curriculum need to be changed every 3 years. We need to have didactic material, soft material available abundantly for people to refer. We need to develop our infrastructure, be it a skill lab, be it a IT infrastructure for teaching learning processes, and strengthening education resources in educational and educational resources. We need to invest largely. Next. So new professionalism I would like to focus here is use competencies as an objective criteria to bring out the new professionalism. Joint planning mechanism is very important. We need to bring all the stakeholders, people from hospitals, what you require from nurses, and that need to be built on professional bodies, academia. Together we need to plan. We are going in compartment. I'm an expert, I'm an educationist, teaching since last 25, 30 years, and I will plan the curriculum. I will decide the competencies. No, that's a bad approach. We need to jointly come. Colonel Binu Sharma, and we should sit together and plan that, yes, these are the competencies, the new professionalism we are expecting from graduate nurse coming out from a university or a school or college of nursing. And common attitude, value, and behavioral soft skills are very, very important. Now the value is of EQ, emotional quotient, social quotient, and spiritual quotient. IQ has taken the back seat, and this has become very important. If you are average, but your soft skills, your EQ is strong, you will be a very, very successful leader, and you will be a change agent. Next. So new professionalism, I was focusing that institutions worldwide are, either government, civil society, organization, business, media, all together must understand what is expected from a new nurse, in a new era nurse, and we need to build that type of nurse. So the consumers will be happy, the healthcare industry will be happy, and healthcare industry CEOs will be happy with that. Next. So realization of a vision is here. We need to go from informative to formative to transformative. Now our education is informative. We are giving a lot of content to it. We can't shift directly to transformative, but we can shift to formative and then transformative. So, information skill too, we should go for socialization values and then the leadership networks. And from experts to professionals and to change agentship is required. And still in India, our education is informative. So we need to have a strong leap quickly. Next. Enabling action is mobilized leadership, enhancement of investments, alignment with accreditation, and strengthening the global learning. Next. So you can appreciate here, we need to bring reforms into instructional level and institutional level. And at an instructional level, we need to have a competency-driven curriculum or education, interprofessional and transprofessional education, IT-empowered education, local global focus, educational resources, strengthening a new professionalism. These are the 6-point focus I would like to reinforce here. At institutional level, joint planning, academic system, global networking, and culture of critical inquiries and audits. And enabling action will happen, those 4 which I have highlighted. And finally, we will be able to achieve the transformative and interdependent professional education for equity into health for nurses. So redesigning nursing education to accelerate changes into healthcare. The 5 things here I would like to highlight is patient safety, quality improvement, population health, in an environment, team-based and patient-centered care. And 2 things which I would like to focus in India immediately is we need to have a uniform entry norms and methods of nursing education, like NEET admission. We need so that the best quality of product enters. And national exit exam with a skill component tested this identified centers, not only just MCQ based theory knowledge, but after that they goes into identified centers. And the work-based assessment, we call it, is for 1 week we observe and we see 360-degree feedback. And then if somebody scores more than 75 on 3 60 assessment, then they are certified as to nurse to be registered. Next. So prepared nurses for tomorrow's healthcare system. Focus is passive to active learning, flipped classroom learning, so that they can learn by themselves and more time to be spent on skill building. Concept-based learning, providing patient-centered care, working in interdisciplinary team, using evidence-based practice, applying quality improvement, using informatics for care, next, or learning. Then preparing nurses for tomorrow's health, I will again reinforce and focus using data and electronic system, online nursing education, new role for nurses, innovators, care integration, geriatric care, interprofessional team, and reinventing nursing education. Next. So new projects to make nursing education to meet future needs are developing flexible competency-based pathway, teaching new content in health system science, work with healthcare delivery system in a novel way, and making technology work for learning, and envisioning the master adaptive learning for learners, and shaping tomorrow's leaders and universal outcomes. Next. Nursing role in 21st century in healthcare system to be focused on achieving universal health coverage, dealing with emergencies, epidemics, and disasters, and achieving population health and well-being. This is the focus of tomorrow. Next. Future directions for nursing workforce policy is there's a serious shortage. ICN is estimating 13 million nurses. Strengthening capacity, nurse mobility and migration, nursing education focused on primary healthcare, universal health coverage, nursing leadership and governance, and policymakers and employers and regulators. So these are the key areas and directions for the nurse workforce policy for future. So here you can see countries should also deliberate on gender-sensitive nursing workforce policies. Globally, the male to female ratio is average 10 to 13% versus 19 to 87%. In India, there's a sudden surge of male nurses, but in rest of the areas, it is not, and we need to look forward. And WHO has also started paying attention that why there's a serious gender inequality into this discipline and what can be done to bridge this. And whether this will have a positive effect or negative effect, still it is need to be understood by qualitative research approach. Next. Policy levelers to enable the nursing workforce is pre-service education and training, workforce inflow and outflow, and equitable distribution, efficiency, and regulations. Next. So here you can appreciate by this flow how from high school education to the training enabling migration and employment and unemployment ratio, and finally what are the factors governing our nursing workforce market and nursing workforce dynamics in country. So future nursing courses on demand. Last but not least, I say that nurse practitioners is picking up like anything. Certified nurse midwives, government of India is also rolling it out. A clinical nurse specialist and certified registered nurse anesthetist. This will be in demand in country, and we need to build our infrastructure to take those young minds to prepare for this, and market is definitely requiring such healthcare professionals. Next, thank you so much for paying your attention. But I will focus on that. These are the areas which will be, the market will be driving the whole education system. Politics, the society, the philosophy, the culture, the pedagogy, the psychology, and technology. Next. So in the way forward is stakeholders to join, and we need to rethink how the professional education need to be reinvented and reinnovated, so that we prepare practice-ready nurses who can quickly get into and they provide safe patient care. Reforms must begin with change in the mind, and then it will happen on ground. Educational reforms are long and difficult process and demands a strong leadership and require change perspectives and work style, good relationship between stakeholders. And I believe that is not impossible, and we will do it. Thank you so much.
Thank you, sir. Thank you very much. And thank you for giving us your view of what the transformation should be and what are the reforms we should put in forth to move the nursing education ahead. As I understand, and you also explained that, yeah, the reforms are going to take a long time, but again, we are moving in the right direction. Thank you very much, sir. So now I would request Amy to give the presentation, and we have an interesting demonstration as well of one of the evidence-based resources called as Lippincott Solutions. So Amy, over to you. Thank you, sir. We can see the screen. Yes, Amy. Amy, you have to unmute, please. We're not able to hear you.
Hi, is that better?
Yeah, now we can hear you. Thanks. Please go on.
Okay, great. Thank you. So I'm here today to provide you an overview of the Lippincott Solutions point of care products and to demonstrate how our solutions work together to provide you with the most benefit and the best value. Clinicians must be equipped to constantly adjust what they do to match the conditions. Nothing has been made more apparent than that in the last year with the battle against COVID. With rising patient complexity, nurses on the front line really need healthcare leaders to reduce the distance between clinical guidance and everyday work that leads to increasing staff flexibility, increasing the capacity of the clinicians to deliver more work, and increasing the number of intended outcomes or things going right. The Lippincott Solutions suite of resources work in concert to enable these efforts. Our point of care products within the Lippincott Solutions suite consist of Lippincott Procedures, which you're seeing now, and Lippincott Advisor. Lippincott Procedures combines the most trusted clinical content with a powerful online workflow functionality that will save time and help staff deliver better patient outcomes. Lippincott Procedures is always current and it's always evidence-based. It aids in streamlining policies and procedures, it standardizes practice, and it helps mitigate risk. It also supports onboarding and the orientation that we've talked so much about today, and helps that competency assessment and tracking using knowledge-based testing and correlating skills checklists. Lippincott Procedures can be used for just-in-time learning at the bedside to assess the progress from novice or novel nurses, as we've talked about, to very proficient nurses. And it also will reduce the risk of errors at the bedside. Lippincott Advisor is a credible, evidence-based resource that's written with trusted clinical content on all clinical topics, and it cites the latest evidence-based resource. Lippincott Advisor is referential in nature, but it also includes resources to support clinical quality, ongoing survey readiness, nurse residencies, or these transition to practice programs that we spoke about, peer review and peer-to-peer teaching, clinically based programs, and other resources for developing staff, such as some of the soft skills that we talked about earlier today as well. As an example, you might have staff floating from areas that they're less familiar with. We spoke about this earlier today, that staff going from one department to the hospital to the other department and not having the skills needed to perform specific procedures for that department. Lippincott Advisor can help with that, as they might not be as knowledgeable as the drugs that are administered for that area, for treatments, for diagnostic tests that are routinely administered in that area. So where do those novel nurses, those nurses that are just going through all their orientations, where do they go for fast, quick, standard information that is evidence-based? One of the systems here in the US, the advisory board, recently recommended that to address the gap between knowledge and experience seen in very early tenure nurses, and to accelerate their transition to competency, nurse leaders really have to provide guardrails that for caring for the patients, to make the right choice easy and the wrong choice more difficult. So Lippincott Procedures and Advisor, when they're employed together, provide those two guardrails that are needed by the nurse for improving the decision-making and preventing care errors, to allow all of the nurse leadership to sleep better at night. So I'm going to come into Lippincott Procedures, and we'll do a couple searches together, but we want to start just here on the front page and show you that in addition to nursing, we also support allied health. So you're seeing respiratory therapy, physical therapy, and you're also seeing a new area down here, which we've are referring to as unlicensed assistive personnel, but that could also be changed to your CNAs or your medical assistants, nursing assistants, patient care technicians. So we'll go ahead and do a search, and you'll see that we have a type ahead that'll come up. So I'm going to search on intramuscular injection and procedures. So you'll see here the layout of the page, the monograph of the information. So we have an introduction, a brief introduction. It goes straight into the equipment needed to perform the procedure, the preparation of the equipment, the implementation of the actual procedure, any special considerations and complications, the documentation, any related procedures, any related patient teaching handouts, and then the references. So I'm just going to scroll through the information so that you can see how a procedure is laid out in Lippincott procedures. These are all standardized, and they'll all be laid out in the same method. You'll also see our references throughout the procedure. And these, of course, are based on what we've talked most about today, all of the best evidence-based practice. You'll also see as we scroll through very crisp images that are able to be used in educational materials at your institution. And you'll also see videos. So these are short video clips that the novice nurse can use before they're going in to see a patient, when they're in between seeing patients, if they need a refresher of a quick procedure before they go in and actually perform that procedure. These are meant to be very quick in length so that the nurse can watch them as they're going. As you see, that one is just 4 seconds, as they're going right before and see the patient. You'll also notice that they have closed caption with them so that if the nurse is watching them on a mobile device, they're able to mute that and just watch the video and see, read the text that goes along with it. As they scroll down to the bottom, you'll see all of the references are included below. And this is what's so important based on what we've been talking about today with the evidence-based practice for nursing, to make sure that they are practicing the latest evidence, the latest procedures based on the greatest evidence. All of those references will be included at the bottom. And then completely at the bottom is our, the system hierarchy that we use here with Lippincott is the Melnick. And so you can see from level 1 to level 7, all of the the references will be leveled as well. I'm going to just scroll back up to the top and show you across the top. So we have the procedure here. Every procedure also has a skills checklist within it. So our speakers today spoke quite a bit about precepting and getting that new nurse ready for treating the patients. So the skills checklists are used by the preceptor to ensure the competencies of all of those new nurses as they're coming out of school and getting ready for practice. All of the images will be contained together as well. So again, if there is a need to use any of those for educational materials within your institution, you certainly can do that. And then the videos will all be gathered together in this tab as well. As we go over to Advisor, this is the tool again for having that great clinical decision support. So when those preceptors aren't available for that novice nurse, this is a resource that they can come, that they're going to be able to get that trusted, quick answers to their questions. So I'm going to go ahead and do a search on sepsis. And I have the monograph here. So here's a nursing care plan for sepsis. So as I expand each of these areas, you'll see what the nursing care plan is. We also have all of the diseases and conditions. So I can type, I can look for any disease and condition here. And I'll just look at sepsis in this area as well. And this is the monograph of sepsis for the disease. You'll notice also the revision date will always be noted in both advisor and procedures so that you can rest assured that you are looking at the latest and greatest information. One of my favorite things about Advisor is it's going to show you really what the nurse should do. So all of the interventions, monitoring that needs to take place, as well as the associated nursing procedures. Over on the right-hand side, we have all of the related information. So it can link out to other resources that you have within Wolters Kluwer, whether it's up to date or something on Ovid. If we scroll down, you can see the additional signs and symptoms, diagnostic tests, and treatments. And then, of course, here in the middle is the main monograph. And this is going to give the nurse that quick, concise, and bulleted information that they need to know to be able to take care of that patient. Lippincott Advisor is much more than just information about diseases and conditions. It also includes patient teaching handouts, teaching about being a nurse. So we know that nurses go to school to be nurses and take care of patients, but a large part of their role is doing that patient education. So this area can help with teaching maybe a non-compliant patient or how to teach a geriatric patient. It really helps bridge the gap for especially nurses going through those orientations to be able to relate better to patients. Maybe they have a test coming up and the patient is very anxious about that diagnostic test. And there's information contained in this area to be able to help the nurse be able to teach about a specific diagnostic test that's going to be performed. So it'll contain information about why it's being done, help both the patient and the nurse prepare the patient for the procedure, the after procedure care, and then just like Lippincott procedures, you'll always have the evidence that's included here. One of the other very popular areas of Lippincott Advisor is our cultural perspective. So we know that living in the world that we live in, we have a lot of different cultures that are going to be coming into our different hospitals and our healthcare systems. So this helps the nurse work with a patient maybe of a different culture, a different ethnicity, a different religion than they are used to, than what they've grown up with. This information is also updated on an annual to a biannual basis within Advisor. There's also one of the other most popular areas within Advisor is the drug information. One of the best things about Advisor is that the drug information is actually updated on a weekly update. So if there's been any changes in, let me just go ahead and do the search. So I'm going to search on latest update. So if there's been any information that's changed on something like a new indication or a dosage for a drug, you'll see this was updated earlier in June, the middle of June. So we're looking at that drug information on a weekly basis and updating Advisor accordingly. And you'll see that the contraindications and the cautions, as well as the nursing considerations, are always listed, making Advisor a must-have product to go right along with Lippincott procedures so that they are able to practice, again, when employed together, they are enabling both the nurse and the leadership to provide those guardrails that is going to help improve decision-making and again, prevent care errors, allowing those nurse leaders to sleep better at night. Thank you very much for your time today.
Thanks, Amy. I think the participants would have had a look at the solution, and few people are interested even. And thanks once again. And we will just go for a few questions and answers. So I will slightly moderate these questions because we have a lot of questions there. So maybe we can have a couple of questions for each speaker. First, I would request Colonel Binu Sharma to answer this question. There is a question: what are the ways to just a moment? Yeah, how orientation will help to overcome the fear, anxiety of the freshers in the hospitals during their training?
Okay, so I think that's a very, very relevant question. It's always the fear of the unknown. So when you understand the hospital environment, when you know which departments are there, how procedures are done, what are the policies, how do you enter a patient room, where do you find the consumables for a patient, where are the medicines, how do you reach out to a laboratory? These are all the questions which will come to you when you are interacting with patients and family members, and even many others who are in the hospital, housekeeping, the laundry guys. So when you are oriented well to all of this, policies, protocols, culture, processes, infrastructure, and what is it you are expected to answer back, that will take away your fear and anxiety. So the fear of unknown will go away. If your onboarding is good, if your induction is complete, you become more confident to answer back patients, family members, and everybody else. That is how it takes away your anxiety and fear. It's always a new place. It is always something new. You do not know about it. That creates a fear element in your mind. When that is not new anymore, you understand, you don't have the fear and anxiety.
Thank you, ma'am. And there are 2-3 questions on the same line. So I'm just giving you a consolidated question, which is nursing retention continues to pose problems for nursing and healthcare organizations, and then for the leaders. How to tackle this? Maybe you can just give some examples.
So let me tell you, this is always a challenge for every organization, the private sector. The nursing leaders always fear the high attrition. People leave for multiple reasons. People do not always leave for money, but people leave for a bad working environment. People leave for disengaged, disinterested organization or organizational leaders. People leave an organization for lack of opportunities for growth, learning, and development. People leave the organization for lack of identity and lack of respect, or lack of clarity of role, or lack of transparency in the organization. So if you take care of engaging with people, talking to them formally, informally, creating a happy environment, creating a platform for upskilling themselves, improving their knowledge, making a platform available for them to reach you as a nursing leader, reach other seniors. Do not allow the newcomers to be bullied by anybody in the system. Protect them, shield them, train them, engage with them, support them, guide them. Very less people will leave you. Yes, people will still go abroad because the salaries there are so very different. When you earn in dollars and pounds, that is so very different when you earn in rupees. People will still go, but the going abroad or overseas is a long process. Let people be transparent. They are getting ready for overseas employment. They will still have 1 or 2 years time, and you can still get the best out of them. So people going to the government hospitals for a better job security, and people going for overseas employment for a very, very high quality of life and a different compensation and a different life for themselves and family are the two factors you may not be able to control. Everything else you can control. We have tried it, so I'm speaking that with a lot of experience of the past. Yeah.
Thank you.
Thank you.
Yeah, that's wonderfully put. Yeah, that answers the question. I think then I have another question for Colette. Maybe it's more of a comparison between a country like India and US. Maybe participants would like to know, like in today's evolving patient care environment in a developing country like India. So where do you see how to decrease the variability of care, so which most of speakers touched, and improve patient outcome? So Colette, can you give your take on the differences between US or maybe India? So maybe you can just briefly elaborate on US and India.
I think that what you need to do is take a look at the best evidence and see where you are as an institution and see what you have available to you as far as keeping your care standardized, and apply that evidence as you can, and educate your staff so that everybody's on the same page and consistently doing the same things to eliminate that variability. I think that one of the things earlier in my talk, when I was talking about Florence Nightingale and how she observed things going on, in her institution and was able to take her observations and apply them, I think that no matter where you are, you can take observations in your facility, in your area, what your resources are, and you can apply the best evidence to the resources that you have available to you. And just getting that standardization in care is really going to help improve patient outcomes in your area.
Yeah, thanks, Colette. So I understand, yeah, the standardization comes from using standard tools. Yeah, so most of the participants would agree with that. So then there's another question for Professor Sharma. So Professor Suresh Sharma.
Hand over this also. You need to download Teams for me.
Yeah. Professor
Just 5 minutes.
Professor Suresh Sharma. So there's this question. How do you find the currently available online nursing tools are best fit in, considering the competency-based curriculum for nursing students, in keeping the pandemic scenario under consideration? So, and maybe what is your view for future education as well, if you can add?
We have just seen Emmy have shown us the Walters Lippincott resources, which other agencies like Elsevier also has done, and they are very useful in current situations like pandemic, where these resources can help to complement and supplement deficit of clinical skills. Yes, definitely hands-on is hands-on. We can't substitute with anything that, but at least they can be oriented how this procedure is done. What are the different techniques? Once they are oriented, they are primed. Once they get an opportunity to come back to lab and or the patient and or the hospital setting, they can quickly pick it up. So these resources are very important, and I suggest that nursing educators must make use of these resources to fill this gap in a current pandemic situations.
Yeah, thank you, Professor Suresh Sharma. I think we have actually overshot our time. So this, I think we can conclude here. And once again, thank you for all the speakers for answering those questions and participating in this webinar. So on behalf of Wolters Kluwer, I thank Professor Sharma and Colonel Binu Sharma and also Colette and Amy for giving their presentation and for all their great presentation. It was a pleasure to have you with us. So to all the participants, thank you once again. So this concludes the webinar, and we hope you have learned and enjoyed the presentation and the talk.
Thank you, Dr.
Thank you. Thank you for having us over, and thank you, audience.
Thank you,
and thank you, Dr. Sharma, for connecting.
Yeah,
my pleasure, ma'am.
Thank you.
Thank you, ma'am. Thank you.
Thank you.
Yeah. Thanks, Ravi. Yeah.
Bye-bye, everyone.
Thanks.
Bye-bye.